Hello, hello. Thank you so much for joining us tonight. Thank you so much for people who are here. We see some good friends in the audience, and also welcome to more than 200 people who are online, virtual today. So there is a big audience. So my first question is, if you have questions, make sure you use the microphone. And of course, we can repeat them so the virtual audience can hear us. So welcome, everybody. It's a great pleasure to be here, a great pleasure to share the stage with great friends and colleagues. On my right here, we have Dr. Zhang, who is a phenomenal GU leader. She's an associate professor, Tian, at UT Southwestern. Want to say hi to the
Hi, everyone. Really great pleasure to be here tonight with Petros and our friend Evan Yu.
Of course, great segue. Dr. Evan Yu, he's a professor of oncology. He's also running a clinical trial office and the section chief of solid tumor oncology at Fred Hutch. He has the office next to mine. I learn from him every day. Evan.
It's wonderful to be here tonight. Thanks so much for having me here. Looking forward to having a real good evening.
Fantastic. Thanks, Tian and Evan, to be here tonight. And thanks, of course, to Peerview, who's organizing this great CME event. And of course, thanks to our friends. I see there Stephanie and Rick and others, and Bladder Cancer Advocacy Network, a great partner for this event. And we have to say that May was Awareness Month for bladder cancer. So we appreciate all you're doing and the partnership in this event and overall in the mission for patient care, research, education, etc. And of course, thanks to their sponsor, AstraZeneca, Daiichi Sankyo, and Gilead Sciences for providing educational grants for making this symposium tonight possible. If you have not already done this, please complete the pre-event survey. We need that data points before we start. And reminder, look out for additional follow-up polling questions that will happen during the presentation. You will see some screens that will remind you to do that as we go forward. And please submit your questions. We will answer them during the Q&A. All the hard questions will go to Tian and Evan. I will take the easy ones. I'm kidding. It's going to be to make it fun and interactive. So please, submit questions, and we'll be happy to answer them. As you see here, would like you to visit us at thepeerview.com/2024 ADC Bladder, and you can view the slides and practice aids. Now you can download them after the event, so those educational material points can be with you and you can keep them, which is great. Our goals for tonight, we're going to attempt to augment our understanding for the current rationales and evidence for treatment for urothelial carcinoma using antibody-drug conjugates targeting Nectin-4, TROP2, and HER2. These are the three targets that now we have FDA-approved antibody-drug conjugates against. So we're going to kind of divide and conquer here. Each one of us will take one of those targets, ADCs, and talk about them. And then we're going to try to equip you with the skills you need to implement those agents, those regimens into your clinical practice and to an ideally personalized, customized treatment plan for your patients. Also, we plan to give you some hints and tips to provide you guidance on how to support a team-based management, what we call a multidisciplinary approach of the unique characteristics of adverse events that are associated with the use of different antibody-drug conjugates, and of course, how we can use that knowledge to manage adverse events that patients may have in the clinic. As I mentioned before, you all have iPads. I know you already had your instructions, your marching orders. Please use this iPad. It's going to be great help for tonight and answer questions on your clinical practice and share your thoughts. Of course, starting off here, we have to acknowledge that there are many opportunities and huge progress that has been made in this disease in the last, I would say, decade, which is wonderful for our patients. Our patients live longer, and we have many more treatment options available for our patients, which is fantastic. At the same time, there are many shortcomings and barriers that we want to remove. You see some of them in this slide. About a quarter to maybe half of our patients may not receive treatment at all for their disease, for bladder cancer. I think that data is probably older. However, and with the advent of new therapies, hopefully more patients get treatment, have more access to treatment. However, it's still, I think, a significant need to improve upon their access to care and availability of therapies globally, not only in the US, so patients can have access to those treatments. Many patients, after progression on immunotherapy on checkpoint inhibition, they may get either another checkpoint inhibitor or chemotherapy agents, and sometimes with less data to support it. So I think it's important to have the knowledge about the data sets for antibody-drug conjugates, targeted therapy like erdafitinib and others, so we can use those in clinical practice. Many patients may not make it to subsequent lines of therapy, so we may have attrition, and I think having more safe and effective therapies can help us keep more patients on treatment and have less attrition over time. And as you see in the right lower corner, less than a third of the patients who may discontinue checkpoint inhibitor may receive another one in the second and third line. We don't have a lot of data about a challenge with checkpoint inhibition. And I think very, very few people, as I mentioned, make it to third or fourth line of therapy. And this is changing. I think this because of the advent of new therapy. So this less than one third of patients who make it to second or third line, hopefully it's more now because we have antibody drug conjugates, erdafitinib, and other therapies to offer those patients. So this number hopefully will be more in the future. Antibody drug conjugates it's a class of drugs. It's a big family of different agents. It's not only one particular drug, and as you see there in that particular slide, they have three main components. They have a monoclonal antibody that target a particular target, for example, Nectin-4, HER2 or TROP2. There is a linker that connects that antibody with a toxin, a chemotherapy payload, and this payload is being delivered as specifically as possible to cancer cells. And you see there's highly specific binding properties of those antibodies to try to select the target as much as possible and deliver as much as possible in a cancer-specific way the chemotherapy payload. And the pharmacodynamic properties of those antibody drug conjugates make them uniquely suited for this, I would say, treatment landscape across different cancers. And the goal is here to improve and increase our specificity and selectivity in delivering the chemotherapy into cancer cells. Of course, there are different characteristics of tumors, like the microenvironment, the immunosuppressive microenvironment, the hypoxic microenvironment, that can also impact the delivery of those payloads, and of course, the significant tumor heterogeneity. Tian and Evan will talk to you a lot, and me as well, about the different antibody drug conjugates that we have in clinical practice. And here you see just in a nutshell, the whole concept is you try to target this particular antigen in the cancer cells. You try to bind that with the antibody part of the antibody drug conjugate, and when this structure gets in contact with the membrane of the cell, the receptor, there is usually an endocytosis process. And inside the cancer cell, there is release of the payload, the chemotherapy payload, to try to distract the cancer cells. And the mechanism of action of the payload may differ from ADC to ADC. So we may have like a microtubule inhibitor or topoisomerase 1 inhibitor, and that may differ, as I mentioned, from cancer cell to cancer, from chemotherapy payload to chemotherapy payload, and that can impact the cancer cell killing effects and the mechanism of that. Also, when you have cancer cell killing, you may have release of the payload in the tumor microenvironment, and that may potentially lead to what we call bystander effects. And you can see there's some diffusion of the antibody there, of the payload there in the tumor microenvironment, and this can kill other cancer cells in the neighborhood in the microenvironment of the tumor. I want again to give a shout out once more to Beacon, the Bladder Cancer Advocacy Network. This is a fantastic resource, excellent resource for patients, families, caregivers, professionals. I think the mission that BCAN, we pronounce it as Beacon, right, Stephanie? Beacon of Hope and Beacon of Light. And this is a wonderful resource again. We have resources, print out materials to patients. We have support lines that patients may call to talk to peer-to-peer lines. We have videos that are animated and people can get information. We have webinars, podcasts. We have a lot of information about treatments, and we have a beautiful clinical trial dashboard. And patients can go in and they can access clinical trials that are relevant to their disease stage, and they can see which centers have these trials available and open. And as you see, there's a support line on the right part of the slide, and of course, there are information on the website, email and phone access information. So a great resource for our patients. So without further ado, I will put the microphone to my friend, Dr. Zhang, and she will talk about Nectin-4 target antibody drug conjugates. Tian, thank you.
Thanks so much, Petros, for that wonderful, broad introduction, and I'm really excited to talk. I think I have the easiest job of the night talking about Nectin-4 ADCs, so hopefully I'll walk through the data for enfortumab vedotin. But so Nectin-4 is a ligand on the surface of cells, tumor cells. You just heard Petros describe this very nice on background, so targeting with our antibody drug conjugates. So Nectin-4 is the target for enfortumab vedotin and other ADCs coming down the pipeline. Nectin-4, in our early studies, we saw expression in urothelial cancer over over 80% of urothelial cancers have Nectin-4 expression, and it's also overexpressed in other tumor types like breast cancer. And the normal tissue expression is actually pretty limited, which helps in terms of toxicity. Of note, though, and we'll get into this a little bit more, Nectin-4 is present on the sheaths of myelin, so myelin sheaths, and it does contribute to some of the peripheral neuropathy that we see in patients treated with enfortumab vedotin. So here's enfortumab vedotin. This is an antibody-drug conjugate directed to Nectin-4 and delivering a payload called monomethyl auristatin E. This is a cytotoxic agent, in fact, that disrupts microtubule formation and therefore causes a cytotoxic effect of stopping cell division. You've heard this maybe described as a smart bomb or a really smart chemotherapy. In fact, it is a targeted form of chemotherapy. So we'll jump right into the clinical data here. EV301 was the registrational trial for enfortumab vedotin as a monotherapy. This was a phase 3 trial randomized for metastatic urothelial cancer that had been previously treated with chemotherapy and also after prior immunotherapy. Randomized patients to enfortumab vedotin as a single agent versus investigator's choice chemotherapy. Usually that would be docetaxel, paclitaxel, or vinflunine. Most of these patients had had prior platinum chemo and treatment until progression or adverse event. And the primary endpoint here was overall survival. And so top line enfortumab vedotin compared with chemotherapy, you're seeing overall survival in that top Kaplan-Meier curve and progression-free survival in the bottom one, and it improved both. So enfortumab vedotin in the refractory setting was indeed better than investigator choice chemotherapy in terms of both prolonging time until progression as well as extending people's life expectancy and making them live longer. The objective responses of note for enfortumab vedotin as a monotherapy is right around 40%, 41% in this trial. So as a single agent, enfortumab vedotin is indeed quite active, and I think in all of our experiences can help patients even in the refractory setting when patients have progressed past chemotherapy as well as PD-1 immunotherapies. These are the long-term outcomes of EV301, overall survival on the left, progression-free survival on the right. And as you see, after a median follow-up of around 2 years, with longer follow-up, we have more mature events, and enfortumab vedotin maintains its improvement in both progression-free survival and overall survival over investigator's choice chemotherapy. So how do we get to combination from single agent? Well, the EV103 trial was a basket trial. It had multiple cohorts, and there was an early cohort, cohort A, that looked at cisplatin-ineligible patients treated with enfortumab vedotin with pembrolizumab combination, showed a really nice early objective response around 65%. And so this cohort K was developed, and cohort K was a randomized cohort that randomized patients with cisplatin-ineligible disease, so first-line metastatic urothelial cancer, to either the combination of enfortumab vedotin with pembrolizumab or enfortumab vedotin alone, so asking the component of the pieces how much more effective was the combination than single-agent enfortumab vedotin. You see baseline patient characteristics here. Most of these patients, over 80% of them, had visceral disease in both cohorts. Many of those patients had lung metastases. A quarter of them had bone metastases, which in bladder cancer we know to be a very poor prognosis. And as you look across these patient characteristics, many of them were our usual patient population, older, Caucasian, and more men predominantly than women. All right, so jumping into the cohort K responses, you see here the enfortumab vedotin plus pembrolizumab combination had 65% or so objective responses, including about 10% complete responses, which was very promising to see, compared with monotherapy enfortumab vedotin right around 45%, so mirroring the EV301 objective responses around 40%. So EV by itself had what we expected it to, and combined with pembrolizumab, certainly an additive effect effect. Some people might say this might be a synergistic effect. I think more studies need to be done to really see how these agents are combined and allowing an immunologic cell death. So based on cohort K then, EV-302 was developed, and this is enfortumab vedotin with pembrolizumab versus platinum agent of choice with gemcitabine in the frontline setting. So all metastatic urothelial cancer eligible for any platinum, whether that's cisplatin or carboplatin, and they were checkpoint inhibitor naive. These patients were stratified by their cisplatin eligibility, their PD-L1 expression, and their presence or absence of liver metastases, and randomized to a combination versus first-line chemotherapy. Patients were treated until disease progression or unacceptable toxicity, and the dual primary endpoints here were progression-free survival and also overall survival. So we saw this data about 6 months ago now at ESMO, and I think the audience was all blown away at the improvement of overall survival of the combination of enfortumab vedotin compared to frontline platinum-based chemotherapy. Up until now, we hadn't seen any agent beat chemotherapy in the frontline setting, so this was super exciting for us and for our patients. I think it really changes that frontline outlook. But hazard ratio here was 0.47, improved for enfortumab vedotin with pembrolizumab compared with chemotherapy, and indeed gained full approval from the US FDA for first-line treatment of metastatic urothelial cancer late 2023. In addition, enfortumab vedotin with pembrolizumab improved progression-free survival. You see here the curves separate early and they stay well separated. Hazard ratio here was 0.45, so risk of progression or death was decreased by about 55% if you go by that hazard ratio over time. I think what was impressive to all of us, and we all had patients on EV-302, was this complete response rate of 29%. And in fact, in metastatic urothelial cancer, I don't think this measure of complete response has ever been, we've never had this high rate of complete response, 29%. Add in the partial responders of 38%, and you have the objective response rate right there, about 67%. So this was truly an improvement compared with chemotherapy in the mid 40% range in objective responses, and importantly, we'll go back a slide. You see some of these responses are quite durable, where there's a plateau effect over time in the EV and pembro treated cohort. So really exciting for our patients and changes, I think, all their outlooks in the frontline setting. When we're looking at treatment-related adverse events, this is a tornado plot of treatment-related adverse events of EV pembro on the left, chemotherapy on the right. The darker colors indicate grade 3-4 events, and the lighter ones are grade 1-2 events. You see that there are some rashes, so grade 3-4 rashes, as well as neutropenia, but overall, more lighter colors on the left side of this plot than darker colors, and certainly compared against chemotherapy, I think the majority of us would say that this combination is tolerable and manageable. So the adverse events of special interest for enfortumab vedotin, I mentioned earlier the Nectin-4 presence on myelin sheaths. So peripheral neuropathy is certainly something that we see quite commonly, especially as we get into cycles 4, 5, 6. Many of our patients will develop peripheral neuropathy. So you see here total events 43, about half of those improved over time, but with resolution less so, about a quarter of patients with resolved peripheral neuropathy over time. So certainly something that we keep in mind and we think about with early dose reduction and dose holds. The skin toxicities are lower, and in fact they're lower in terms of improvement and higher with resolution of skin toxicities. So these can be managed quite well during the course of skin dose reduction and dose holds. And you see the improvement less than a month for skin reactions to improve, a little longer, more than 6 months for neuropathies to improve. And the hyperglycemia is pretty rare, but when we see it, certainly when patients are in our clinics and their glucose levels are over 250, we're holding treatment, and certainly something to monitor as our patients are going on EV. There are some grade 3 and higher severe skin toxicities, pneumonitis, colitis, and hypothyroidism that we think are more immune-mediated. So we're also careful to separate out what's from the immune treatment and what's from enfortumab vedotin. Some of the ways that we can manage these toxicities in the clinic, holding early, telling our patients what to expect and what to look out for. So the early recognition of skin toxicities, of rashes, of bullous lesions, we're absolutely holding. If they're just having grade 1, 2 macular papular rashes, we're giving steroids early and antihistamines. But certainly grade 3 or higher, we're holding and allowing that resolution to occur before any thought of re-challenge. For peripheral neuropathy, this is sort of a cumulative event and certainly worsens over time as we give it. And it's important for grade 3 or higher to permanently discontinue enfortumab vedotin. There are some ocular events. We have not seen this as commonly as for other targeted treatments, but certainly prophylactic tears and also ophthalmologic steroids are helpful when they occur. We certainly try to get our patients seen by our ophthalmologists if blurry vision or any other vision changes occur during treatment. Hyperglycemia I mentioned already, over 250, we're holding, and it's part of the box warning. And pneumonitis, I think, is also a possibility, and that we're discontinuing for persistent or recurrent grade 2 or any grade 3 or higher. We're permanently discontinuing enfortumab vedotin. All right, so some take-home points from this section. Enfortumab vedotin now is approved as a monotherapy and is effective as a standard agent for refractory metastatic urothelial cancer. So in our clinics, we have patients who are progressing after frontline chemotherapy, second-line immunotherapy agents. Now enfortumab vedotin certainly is a good option for them in refractory disease. The combination of enfortumab vedotin with pembrolizumab is now very standard for all comers in frontline metastatic urothelial cancer. You saw the improvements of progression-free survival and getting patients to live longer, overall survival, and that 29% complete response rate that was unprecedented. So changing what the outlook is like for patients diagnosed with metastatic urothelial cancer. And this is essentially, enfortumab vedotin is essentially a targeted chemotherapy, and I think we really need to think about managing these toxicities. Most of these patients will develop peripheral neuropathy over time, so early dose reduction and dose delays will really help mitigate and hopefully prevent those very severe side effects that might occur. And I think many of us, even though enfortumab vedotin only has bladder cancer as its a single indication, many of us are getting comfortable in our practices to give it and also to help patients get through the side effects in an early and ongoing way. So with that, I'll turn it back over to Dr. Grivas and take us through the case.
Fantastic job, Tiana, as always. A great comprehensive data overview in a very nice way, and you have a lot of experience with this drug. So let's talk a little bit about this patient here, so I can ask both you and Evan. So a 65-year-old patient presented with hematuria. Again, Bladder Cancer Awareness Month. Hematuria is the most common presenting symptom of bladder cancer. There's a lot of campaign out there to make sure we don't delay diagnosis. So this patient had proper workup, cystoscopy with TURBT and urine cytology, confirmed histological to have urothelial carcinoma. There was no variant subtype histology. The CAT scan showed significant lymphadenopathy, both in the pelvis and also retroperitoneum, so retroperitoneal space. So this is an M1A stage 4. Creatinine clearance is 60 ml per minute, ECOG PS1, some hypertension, mild anemia, but no challenges with neuropathy, hearing loss, no heart failure, no autoimmune conditions, no steroid intake, and this patient had a tumor next generation sequencing, which we do at the time of diagnosis of metastatic disease to look for potential therapy targets, and there was no FGFR3 alteration present. And also, because of the data that Evan will talk about in a little bit, we also do HER2 protein immunohistochemistry these days for metastatic urothelial carcinoma, and this patient, this staining was negative for this particular patient. So let's start with Tiana, with you. Think about that patient. When you meet them in the clinic, you discuss the treatment plan. What are the things that are important to you in terms of deciding treatment? What factors do you take into account for decision making?
Well, I think a lot about their comorbidities and how they're coming into the clinic and their distribution of metastatic disease. Now, for all comers, we just talked to the intention to treat population was really all comers. There was no biomarker selection for EV302. And so I think this is a very typical case that comes through the door that I would offer enfortumab vedotin and pembrolizumab for. The lymph node predominant metastases is actually a good prognosis marker for our metastatic urothelial cancers. And so I would be very positive in thinking, this is a patient who may have a very nice response. And I don't see anything in terms of neuropathy or other comorbidities that would prevent me from giving enfortumab vedotin and pembrolizumab.
Fantastic, Tiana. I agree with you. And maybe I will ask you a question before I ask Evan. You mentioned that you don't see any particular comorbidities that would prevent you from using Pembro-EV. Are there any medical conditions in your mind where EV may not be your fair choice, if relatively contraindicated, or if any?
Yeah, I think uncontrolled diabetes, if their sugar levels are all over 250, that's a challenge, right, for enfortumab vedotin. Any autoimmune disease that's requiring more than steroids at a very low dose, we may also hold off on giving pembrolizumab for. So those are the two that I'm looking out for that are pretty common in our real-world patients that I think we should be thinking early about, maybe alternative strategies or giving a single agent instead of both when they come in.
Thanks, Tiana. Great points. And Evan, what about neuropathy? Do you have like a cutoff of, how do you assess that in clinic, and what's your kind of cutoff of using or not using enfortumab?
Yeah, I think neuropathy is really important here. If I had a patient that had grade 2 neuropathy or greater, I probably wouldn't offer them EV Pembro either, and I might think about using something like gemcitabine carboplatin. Obviously there's data with gemcitabine, cisplatin, and nivolumab as well, but I think most of us are pretty impressed with the EV Pembro data. But if somebody actually had grade 2 neuropathy, and what defines grade 2 is kind of unique, is that everything's graded differently on the CTCAE scale, but grade 2 is where function's actually affected. So you can have a sensory neuropathy that's uncomfortable, but grade 2 is where you can't button your buttons, you're walking differently, you can't screw in a screw because of the neuropathy. So that's something that I would screen carefully for. Fortunately, this patient has none of those issues, and I agree completely with Dr. Zhang here.
Perfect. Your point is, both of your points are well taken, and the grading is usually with a CTCAE, and that grade 2 is impact on daily activities, which is important. And when you talk to the patient, Evan, about expectations of dosing, scheduling, how do you approach that? Do you talk about dose reductions up front? Do we start the dose?
Yeah, I do. There's not a definitive way to do this, but what I tend to do is I hit people with full dosing because I think that's important, and there's going to be an abstract presented here that shows really the PK and the dose exposure really matters quite a bit. So I would go full dose up front, which is in this situation in combination with pembrolizumab, it's 2 weeks on, 1 week off. And I would induce a response first and demonstrate that radiographically. And then I may be a little unique in this, but I start to pull back. So I start to dose reduce or even start to hold certain doses and give it less frequently, the enfortumab vedotin, because I'm trying to preserve the ability to give as much as possible without inducing the neuropathy.
So you do dose reduction, so you tell the patient that most likely we're going to introduce dose reduction, it's okay.
Right.
Give them a heads up so they don't exactly. They don't report. Great point.
And to add to that, we see plenty of efficacy at the 1 milligram per kilogram dose. And so early on, if to Evan's point, we're thinking about even coming in a little lower if they're really at grade 2 neuropathy at baseline, and we want to minimize any additional neuropathy. But we really want to give them the efficacy of the combination. I'm pretty lenient on dose reducing as a starting dose.
That's a great point. Thanks, Tian. And think about adverse events. We talk about neuropathy. What about the skin rash? What do you tell the patient about the skin rash, Tian, in the clinic?
Yeah, I tell them rashes are very common, and it's as a melanoma friend once told me, it's a sign of their immune system mobilizing. So in immunogenic and immune responsive tumor types, it's a good thing to have rashes as side effects of treatment. It means their immune system is moving and it's potentially attacking the tumors. So for me, it's early education and making the patients aware of the fact that they can have rashes, and as they occur, helping them treat that, antihistamines, steroids, topical steroids to start, oral steroids if the topicals don't work, and then if they're bullous lesions, getting them more specialized attention. So at many of our centers, we're very lucky to have oncodermatologists, and so we have these colleagues who specialize in toxicities on the skin from our immunotherapy and in our targeted treatments, and so getting them in with those specialists, and also potential hospitalizations if severe enough, in order for IV treatments to be given. So it's that early recognition and treatment that hopefully will get them through, and then as we go into dose holds, then really thinking about dose reduction if we're encountering a severe skin reaction, or just leaving off the EV. So we've had patients who have had bullous lesions, TEN, Stevens-Johnson's spectrum type of skin disorders, where we've been very uncomfortable to re-challenge. And so for those patients, maybe backing off until absolute resolution, and then thinking about just the IO only, instead of the enfortumab vedotin.
Got you. Thanks, Tian. Evan, very quick question. What do you do about glucose monitoring in diabetic patients and non-diabetic patients?
Yeah, I mean, I think if you look at the data, hyperglycemia is not like a super high risk thing. We're much more common to see neuropathy. We're much more common to see mild skin changes. I think just dry skin is very common with enfortumab vedotin. But that being said and done, hyperglycemia can happen. The patient population I worry the most about are more advanced age populations, and especially patients with higher body mass index. Certainly those patients who already have diabetes. So it's something that I check every time they come in for an infusion. So, and I'm keeping a close watch on it. And this is a situation where, if they already are on some anti-hyperglycemic medications, I'll work closely with the primary care doctor if it starts to get out of control. If they're not, I've oftentimes just started people on it as well, and we'll manage it. But I think this is an opportunity for good team patient care decision making.
Which actually is a great segue for the last bullet point there, which team members are very important. And obviously we have nurses, we have advanced practice providers, pharmacists. Evan just mentioned primary care team, dermatologists, Tian, you mentioned. So it's a team sport.
Right.
It is, absolutely.
And I think it's important the rash is, we have to sometimes determine whether it's an enfortumab rash or whether it's an autoimmune rash from pembrolizumab. And similar with neuropathy, you can get motor neuropathy as well. And so we've had situations where we had to try to distinguish whether it's neuropathy from enfortumab or pembrolizumab, because we obviously treat them differently. And so we can need the help sometimes from neurology as well.
I remember, we had this discussion that sometimes rarely you may see demyelinating neuropathy from checkpoint inhibitors, more symmetric proximal weakness. So something you can keep in mind. Mostly use enfortumab most of the time, though. So it's a great discussion points. Wonderful. Thanks, both of you. Really, really great to talk about all these details. Again, reminder to the audience here, please take a moment to answer your follow-up questions or you have learned, we want to gather this data helpful for us. So I'm going to continue over here to talk about TROP2 targeting. Tian did a great job with the Nectin-4 targeting and Fortumab specifically. In the TROP2 targeting arena, we have a bunch of antibody-drug conjugates, and obviously we have much more data with sacituzumab govitecan. We'll talk about that today, and of course there are others that are in the development, different phases of the development. So why TROP2 as a target, right? As Tian showed with Nectin-4, TROP2 is expressed. This is a gene expression data across tumor types, and you see that TROP2 as a gene is highly expressed across tumor types. This is data from the Cancer Genome Atlas project with high expression in urothelial carcinoma, and that's why urothelial carcinoma was one of the first tumor types where we actually have sacituzumab govitecan being developed, and TROP2 targeting agents started there, and of course along with breast cancer as well. So you see here, this is protein data. The previous was gene expression, this is protein. And you see here that you have across different subtypes, you may have different expression. And I would say, based on our experience, we studied this, and we have a study at UW Ferhat. Evan is part of it, and we actually consent patients before they pass to do a research autopsy, which is very inspiring from the patient standpoint to do that. And we looked at that, and we look at TROP2 and Nectin-4 expression, and we show expression across different subtypes, variant histologies, with the exception maybe of neuroendocrine. Neuroendocrine seems to be a little bit unique in that does not express that much those targets, TROP2 and Nectin-4. But we also have seen data that from limited studies, of course, that patients who may develop resistance to enfortumab vedotin, the drug that Tian talked about, some of them, they may lose Nectin-4 as a potential mechanism of resistance, maybe other mechanisms as well, and those patients may retain TROP2. So sacituzumab govitecan could be given after enfortumab in those cases, since TROP2 is being retained in that context. We already discussed that there are different ADCs out there. These are just examples of that. On the left, the sacituzumab govitecan, let's call it SG. And on the right, the datopotamab deruxtecan, that is also in early stages of development. And both of them, they target TROP2. There's some difference, of course, as you see in the structure. And you see the payload there is different. But both of those payloads are topoisomerase 1 inhibitors, and I think that's relevant when the ADCs were developed in the beginning. I think microtubule inhibitors and topoisomerase 1 inhibitors were easier to be manufactured and be linked with the antibody, so that you see here the common feature of topoisomerase 1 inhibitor being the chemotherapy payload. Specifically, SG is a first-in-class TROP2 antibody drug conjugate, has approvals in both breast cancer and urothelial carcinoma. You see here the structure. The antibody against TROP2 is a humanized antibody, and you see that it's linked with a linker that is hydrolyzable linker with SN38. SN38 is an active metabolite of irinotecan. So again, a topoisomerase 1 inhibitor with a high drug-to-antibody ratio. You see almost 7 molecules to 1 in terms of drug to antibody. And this mechanism, as I mentioned before, the targeting of TROP2 results in internalization and enzymatic cleavage by the tumor cell of this conjugate. So the metabolite of irinotecan SN38 is being released inside the cancer cells and results in cancer cell killing through inhibition of topoisomerase 1, which is important for DNA replication and other functions. And as I mentioned in the right lower part of the slide, you see the indications of SG. You have 2 indications in breast cancer, triple-negative breast cancer, with at least 2 prior chemotherapies, and there is also a second indication in a hormone receptor-positive breast cancer after prior therapies. And in the urothelial carcinoma, there is an accelerated approval by the FDA that happened in April 2021, about 3 years ago, in patients who had progression on prior platinum-based chemotherapy and prior checkpoint inhibitors, so third line and beyond. Or you can argue second line and beyond, depending on where you give the checkpoint inhibitor. And that label has been since, as I mentioned, 2021. Trophy U01 is a multi-cohort, multi-center international trial, phase 2 trial that actually led to the initial accelerated approval of SG in metastatic urothelial carcinoma in this population of patients that I just talked about. There you see different cohorts in this trial. It's hard to remember all of them. We're going to focus most on the first 3 cohorts. Cohort 1 led to the accelerated approval of SG, again in patients after platinum-based chemotherapy and after checkpoint inhibition. And that particular drug was given as a single agent in that cohort. I will show you the data. Cohort 2 was also monotherapy data with SG after checkpoint inhibitor alone. So patients who got, for example, Pembro or Atezo, back in the day in the frontline setting, and they were cisplatin ineligible, they got Sachi second-line single agent. And cohort 3, this was a combination between SG plus pembrolizumab, so an ADC-IO combination in the second-line platinum refractory setting. Cohort 4, 5, and 6 have not reported data yet, are all in the frontline setting. Cohort 4 evaluates cisplatin plus Sachi, so to see that combination in the cisplatin-eligible population. Cohort 5 looks at sacituzumab plus avelumab or another checkpoint inhibitor called zimberelimab in the maintenance therapy of cisplatin-eligible patients. And cohort 6 looks at cisplatin-ineligible patients who cannot get cisplatin. They can get either Sachi alone or with a checkpoint inhibitor or with another immunomodulator or compared to carbogem followed by avelumab maintenance. The cohort 4, 5, and 6 have not shown data yet. So cohort 1, again, to recap this point, this is monotherapy with sacituzumab govitecan in patients who had prior platinum-based chemotherapy and checkpoint inhibitor. They may have had more therapies. It was a range of treatment. I think the range goes between 2 and 8 prior lines of therapy. So a very heavily pretreated patient population with multiple prior lines of therapy. The initial data in these 113 patients were shown, I think it was 2021 when we published the manuscript at JCO with Scott Agao and others. And at that time, the response rate was 27%. With a little bit follow-up, we just published the updated data with Dr. Loriot and colleagues just a few months ago. At 28% was the response rate, again, with this longer follow-up. Median duration of response about 8 months. Median PFS a little bit more than 5 months. And median OS approximately 11 months. Obviously, this is a single-arm, not randomized trial with Sachi in this heavily pretreated patient population. And you see the waterfall plot with about 3/4 of the patients had reduction in the tumor size, reduction in the tumor burden, showing the efficacy of this agent in the heavily pretreated patient population. And you see here in that slide on the left upper corner, the spider plot. Some of those responses were durable, some were less durable. There was variability there. And on the right lower corner, you see the swimmer's plot. You see that most responses occurred early on at the time of the first scan, which is the time usually you see response with enfortumab, or dafitinib, other agents, usually at the time of the first scan. Some of the responses happen later. So patients may have stable disease and then they converted to response. So you see the durability was variable across patients. So the TROPiCS-04, that's I would say one of those data sets that have not been presented yet, but a lot of discussion in the last 48 hours because of a press release. This trial was designed by our team a few years ago, way before the pandemic, and this was to confirm the data from the cohort 1 of TROPiCS-01 trial, randomized phase 3 study, very similar design to what Tian mentioned with the V301, similar population. Patients had prior platinum-based chemotherapy, prior checkpoint inhibitor, as you see on the left part of the slide, and they were randomized to Sachi, 10 milligrams per kilogram on a day 1 on day 8, on a 21-day cycle. That's a classical standard way we give sacituzumab on the 3-week cycles given on days 1 and day 8. And the control arm was either docetaxel or paclitaxel in the US or vinflunine in Europe. And vinflunine has indication in Europe, not in the US. This trial had the primary endpoint of overall survival and a plethora of secondary endpoints of PFS, response rates, and quality of life metrics. As I mentioned a minute ago, 48 hours ago, there was a press release without data presented that mentioned that this trial did not meet the primary endpoint of overall survival. Obviously, we have to see the data, we have to dissect the data, and hopefully present them in a meeting in the near future to understand better exactly the nuances. Some people may have seen the press release. There was discussion about some neutropenia events with sacituzumab. We'll talk about them today. And I think that makes the point that we need to use growth factor upfront as primary prophylaxis. And I'm going to ask Tian and Evan if they do that in their practice in a second, but that's, I think, is an important parameter to use GCSF upfront with this drug. So this is cohort 2 data. This is SATSI's single agent, single arm trial after checkpoint inhibitor. As you may remember, checkpoint inhibitors were used back in 2017, 2018, 2019, frontline in cisplatin-ineligible patients at the time. And this is SATSI's single agent second line after checkpoint inhibitor. 32% response rate, median duration of response about 7 months, median PFS about 6 months, median OS more than a year. So promising, of course, data, single arm study, and this was presented by Dr. Petrylak, and I can tell you the manuscript is already accepted and hopefully will be actually published in the next couple of weeks in a very prestigious journal, so you can see the data in print. And the response rate was 32% second line. We actually published the cohort 3 data just about 3 months ago. This is platinum refractory setting, second line. Patients got platinum chemotherapy, had progression, did not get maintenance avelumab because of progression, and they went on to second line treatment, and they got sacituzumab plus pembrolizumab combination in a pure second line platinum refractory scenario. And this patient, there were 41 patients, and the overall response rate by central review was the primary endpoint. And you see median follow-up about 15 months. That trial actually met the primary endpoint. We saw 17 responses out of 41 patients, 41% response rate. About half of them were actually complete responses, and the other half were partial responses. Median duration of response approaching 1 year, median PFS a little bit more than 5 months, and median OS exceeding a year. Again, this is a single-arm study. This is not practice-changing, but definitely set the stage for a phase 3 trial that was already designed. And Monica Joshi, my friend from Dr. Joshi is from Penn State, she's the chair, and I'm the co-chair of that trial. And this is a phase 3 study from ECOG-ACRIN 8231. We're going to try to answer the question of IO rechallenge. So the question in that study is, you have patients who had prior immunotherapy, EV-Pembro or adjuvant-nivo or maintenance avelumab, you name it. Any immunotherapy, let's say prior therapy, is an entry point. Patients are allowed and will be stratified if they got platinum chemo and enfortumab before. I assume many may receive that and be stratified based on that. And then we allow up to 2 or 3 lines of therapy for metastatic disease. And we try to answer the question of IO rechallenge with pembro added to SG versus SG alone. Primary endpoint will be overall survival. We hope to open this study in the next probably 3 months or so. And of course, we saw data earlier today from Dr. Siliola from Milan, Italy, and Dr. Necchi did a great job with SHORE-01 study. This was a neoadjuvant trial, so not metastatic disease that we talked about so far, but neoadjuvant preoperative trial looking at neoadjuvant sacituzumab govitecan in patients who were going for a radical cystectomy, and they got, as you see, 4 cycles of sacituzumab, the dose of 10 milligrams per kilogram on days 1 and 8 on a 21-day cycle. The data actually was shown earlier today, and I can summarize it for you. Initially, when the study was launched, there were some neutropenic events. Again, the same story that I mentioned before. And the study was amended to actually mandate a GCSF growth factor to be given upfront with primary prophylaxis with SATSI. I think they lowered the dose from 10 to 7.5 mg per kg, and they excluded very high-risk patients for neutropenia. And after these adjustments, the study was viable, feasible, and they finished accrual. And they showed a very promising, more than 40% pathologic complete response rate with sacituzumab alone monotherapy, which I think it shows activity, of course. We have a study, similar study with Evan at UW for Hatch. We'll look at neoadjuvant SATSI in histology subtypes, variant histologies, bladder cancer, excluding neuroendocrine, and we're going to hopefully have data in the future. This is not practice-changing data, but just shows activity in the neoadjuvant setting. SOAR-02, we did not see data today, but this is SATSI plus pembro neoadjuvant preoperative, and we have to see data in the future. Obviously, there is all this idea about combining antibody-drug conjugates, and our good friend Dr. Sompavde and Dr. McGregor at Dana-Farber did this very interesting study called DAD, double antibody-drug conjugate phase 1 trial. They combined the 2 ADCs, the EV that Tian presented and the SG, and that trial was done in a patient population with previous treatments. So it was a pre-treated population with metastatic disease. with SG plus EV. And as you see in the right part of this slide, there was safety data, and they were trying to figure out the right dose if you combine the two ADCs together. And they were able actually to discern that based on toxicity and efficacy and the totality of the data, they showed an overall response rate of 70%, which is pretty impressive in 23 available patients. Obviously, this is a small sample size, but definitely generates enthusiasm for more data to look at this combination in more patients in larger studies. And based on the toxicity data, they saw that SATSI of 7.5 mg per kg and EV at the full dose on days 1 and 8 on a 21-day cycle was the way to move forward. And there is now, of course, discussions about expanding that study and looking at this combination even in the frontline setting, potentially with IO as a triplet therapy. So more to come. This is definitely not ready for prime time. It's early data, hypothesis generating, and we're going to open and do more studies looking at this combination plus minus checkpoint inhibitor. So stay tuned for the future. The other ADC, in addition to SATS, is datopotamab deruxtecan. The Tropion Pan-Tumor01 trial is shown in this slide. This is adults with multiple different cancer types overall, including, of course, urothelial carcinoma. As you see in the left upper corner, patients had urothelial carcinoma specifically in this cohort, and they had at least one prior line of therapy, no prior treatment with a deruxtecan component of an antibody drug conjugate, because you do not want to have the same payload, right, that given before. And ECOG PS0-1, the dose was 6 milligrams per kilogram every 3 weeks, monotherapy with Dato-DXd, and there were 33 patients with urothelial carcinoma. Primary endpoint was safety, technically like a phase 1 approach. And you see in the lower part of the slide, if you look at the response rate or confirmed response rate in all response available patients, was 19%, approximately 20%, and patients with 2 post-baseline scans, again, 22%. So early data of efficacy, again, small numbers there. It's hard to compare across trials, but you see an approximately 20% response rate and about 80% disease control rate, including CR/PR and stable disease with this agent. So more data to come in the future, I think, is still early in the development, but something to look at. And you see here the waterfall plot, and you see that patients had a significant reduction in the tumor burden. About 82% of patients, significant proportion, had reduction in the tumor burden. So this definitely raises enthusiasm, and this is further evaluated as monotherapy and also in combination with other agents in 2 clinical trials, the Tropion Pan-Tumor02 and 03 trials. So more to come with this drug. Obviously, toxicity is important. I alluded to that before, and sacituzumab has the payload of topoisomerase I inhibition, so bone marrow suppression can happen. Again, my point is, if you use sacituzumab in your clinic tomorrow or when you go back home, do it with growth factor upfront as primary prophylaxis in the first line. I think, personally speaking, this is a critical point, and we'll see, of course, the TROPiCS-04 trial data, but I think based on the press release, that's a very important point that may have played a role. Dose reduction or delay as needed, of course, is the same thing that Tian mentioned with EV. Patient education is critical, very important, and we're actually having the nurses call the patient after starting therapy, following up, make sure they're doing well, and we make sure they know if they have diarrhea. That can happen in about half of the patients, maybe 60% of those. It's usually grade 1, less commonly grade 2, and only 10% is more than like grade 3. We ask them to call us immediately, make sure there's no infection, and we use anti-diarrhea medication, things that can atropine-like molecules like defenoxylate and similar molecules to manage diarrhea aggressively. Rarely, you may need to use hydration with electrolytes, but I think the best supportive care with anti-diarrhea medications and growth factor are critical for the optimal management and optimal dose delivery of those patients. We have not seen data with a dose correlation with response, the data that we'll see with enfortumab, but I think will be critical to see that in the future. Again, we talk about nausea and vomiting can happen, so pre-medication with 5-HT3 antagonist, ondansetron, for example, or palnositron can be used. Dexamethasone could be used if people want to prevent nausea and vomiting. Hypersensitivity reactions are not common, but can happen, and rarely can be life-threatening, so pre-medication with antipyretics, H1 is 2 blockers, prior to infusion to prevent those from happening. We talk about diarrhea, and we talk about the optimal management, have the anti-diarrhea medications at hand at home, and neutropenia, as I made the point before, growth factor is critical upfront. You can be a pegylated form on day 8. That's the easiest way to do it. Some insurance companies are peculiar and they want to give daily growth factors. In those situations, I give it on day 2 to 6 in between, and right, and day 1 and day dosing, and then 9 to 15. So usually it's if the insurance wants a daily administration. Otherwise, day 8, a pegylated form of growth factor is fine. And again, similar discussion here, a little bit different toxicity with datopotamab stomatitis. Mucositis was more common. Nausea, about a third of the patients. Fatigue can happen with both of those ADCs. Anorexia, alopecia, taste changes, and because of the deruxtecan compound, sometimes pneumonitis can happen. So we keep an eye in those patients with the deruxtecan compound. And there's some tips about mucositis: gently brushing of the teeth, daily use of this mouthwash, steroid-containing mouthwash. Education is important. Artificial tears for dry eyes, and avoid contact lenses to avoid any ocular events. Again, the importance of the multidisciplinary team. Education is key. We have, advanced practice providers, nurses, pharmacists, part of the team. And I think that is a very important point we discussed before with Evan and Tian, that we frequently talk to other specialties, non-oncologists, to manage those patients, not only for immune checkpoint inhibitor side effects, IRAEs, but also for side effects from these agents. So after all these data sets we talked about with TROP2 ADCs, I'll go back to a case here. This is a different patient than before. 72-year-old patient with progression of disease, had fatigue, back pain. This patient was previously treated with Gemcis, followed by maintenance avelumab, so the classical Javelin Bladder 100 paradigm. The CAT scan at the time of progression showed liver and bone metastasis. These are negative prognostic factors compared to lymph node only disease. ACOPS1, still functional. NGS of primary tumor did not show any of FGFR3 alterations. The HER2 protein staining was only IHC1+, which is not enough for TDXD. We'll talk about that in a second. This particular patient, again, after Gemcis avelumab, Gemcis maintenance avelumab, has progression, but has high hemoglobin A1c, 9.2%, has not seen an endocrinologist ever, and managed with his primary care provider, not always compliant sometimes, and also had creatine neuropathy. That may be because of the diabetes, maybe because of prior cisplatin. And also the interesting thing, this patient had this CAT scan that showed the liver meds, but also a cirrhotic liver appearance in the CAT scan, which we don't know to fatty liver mediated. There was no history of hepatitis, but no history of cirrhosis, just this appearance on the liver. So I will start with Evan, with you in that case, and then I will go to Tian. So, think about those comorbidities, uncontrolled diabetes, creatine neuropathy, this cirrhotic liver appearance, a little bit of also obesity. How would you approach this patient after Gemcis followed by avelumab?
Yeah, I think this is a patient that's not the ideal patient for enfortumab vedotin for various reasons. The grade 2 neuropathy, as I mentioned earlier, the hemoglobin A1c. So although typically I would reach for enfortumab in this situation, I wouldn't in this situation. He's not eligible for erdafitinib because there's no FGFR alteration. And IC1 plus currently, there's no approval for 1 plus, only 3 plus, although there might be clinical trials that might be testing it for 1 plus patients. So in the situation where there aren't any other clinical trials available, I certainly think that sacituzumab govitecan would be appropriate here in this situation.
Thanks, Evan. And in the absence of trials, you will go for SATSI. What's your opinion about this cirrhotic liver appearance? There's some anecdotes here and there, maybe more toxicity with enfortumab. Any comments on that?
Well, I mean, I've heard of the anecdotes here and there, and it makes some sense. I mean, I think some of the hyperglycemia issues might be hepatic generated issues as well. I've certainly seen some anecdotes like that. I think in this situation it's not as relevant because I'm leaning away from enfortumab anyhow. If I didn't have any of the other comorbidities, I might go for it and see what happens. But but since I do, yeah, I'm not going to give enfortumab in this patient.
Gotcha. Thanks, Evan. Tian, what's your approach here? And would you have the same approach? And if so, how would you counsel the patient about the dosing and side effects?
Right. I would completely agree with the uncontrolled diabetes and the neuropathy. Not a good candidate for enfortumab vedotin, although, if we took those away, this would be a good setting. The cirrhotic liver appearance, it doesn't, as on its own, doesn't inhibit the ADC treatment as long as the LFTs and bilirubin are still within normal. I think when we're talking through the neutropenia potential, my threshold to give growth factor is quite low, especially with a chemo pre-treated patient who's a little bit older. Their bone marrow reserve is not quite as high, so certainly adding a prophylactic growth factor would be high on my list of priorities as I'm starting this person on sacituzumab govitecan.
And would you give them like Imodium or Lomotil to have at home?
Absolutely. Yeah, we build in some of these in our beacon plans for treatments, and so they'll be written in pre-medications that we'll send along so that they'll have it as needed at home, and as the diarrhea occurs, they can have Imodium and or Lomotil and be really prepared to try to control those side effects as much as possible.
Gotcha. And do you have like the nurse working with you call the patient? How do you manage that follow-up?
Yeah, usually the first week or so. So the good thing about this is day 1, day 8 dosing, and so we're seeing them back in the clinic within the week of their first dose. So that's helpful, early follow-up and turnaround. And then as they're off for 2 weeks, then we're following up with a phone call perhaps in that third week off of cycle 1, and then as they get used to managing side effects, that can be less frequent. Sometimes the day 8 visit is skipped. They just get their labs and go to treatment. So as people get comfortable with the side effects of sacituzumab govitecan, they also can become a little bit easier to manage in the clinic. But I do think touching base at least day 1 every cycle is pretty important to ensure that people are tolerating, their side effects are managing, and as we get scans, right, repeat scans every 12 weeks or so is my standard, or if any clinical signs develop, we're monitoring for disease progression.
Awesome. Thank you, Tiana. Very, very helpful. So again, a reminder for you guys to answer the follow-up questions of what you have learned so far. It's great. Thank you for doing that. And as the next topic, Evan, you're on for HER2 ADCs, my friend.
All right, I get to talk about the new kid on the block. Well, actually, this is the oldest target on the block, but
right.
It's the newest in terms of recent FDA approvals and therapeutic drug development. So this is just a little background information on HER2, and this is just a little data that I pulled on overexpression, amplification, mutations across all different tumor types. And of course, we're talking about bladder cancer today, so I'm highlighting bladder cancer. You can see that 8.8% or 8.6% amplifications, 12.4% overexpression, and 9% actually have HER2 mutations. And we're starting to learn that patients with HER2 mutations may respond to some of these HER2 antibody drug conjugates as well. So just a little bit of background data there. Now, there's a little bit more data that we've been working on to try to understand just how common it is to see high HER2 expression for patients with urothelial bladder cancer. And this is a little data I got from Vadim from UCSF. He was kind enough to share a couple slides with me. And what they did is they went through the literature, systemic literature review of reported HER2 status in locally advanced and metastatic urothelial carcinoma, and really looked at HER2 expression using predefined criteria. And what they found is that HER2 high, which was defined by immunohistochemistry scores of 3+, or immunohistochemistry scores of 2+ or plus-ish positivity, they found that their weighted average was 12.3%. And they had 6 studies and 971 patients they found to establish that using these predefined criteria. Now, HER2 low, which was essentially IHC 1+, or the IHC 2 plus and ISH negative patients, they actually found was quite high in this population, 47.9%. And this was from 4 studies and 275 patients, but it's kind of relevant because if you look at the field across of oncology, we know that in breast cancer, it was pretty earth-shattering when we saw the HER2 low plus patients have really outstanding results with HER2-targeted antibody drug conjugates. So even those HER2 low patients with bystander effect, we need to think about whether these patients might benefit or not moving forward as well. So Vadim's group took it another step, and they looked in their own resection samples from primary urothelial bladder cancers, from transurethral resections and surgical specimens in 362 patients, and they used a prospectively planned HER2 expression methodology using the Ventana HER2 rabbit monoclonal primary antibody IHC assay, and they used the dual ISH DNA probe cocktail. And what they found here was pretty similar and consistent, and this is really the scoring system based on the gastric cancer scoring system that we use regularly for determining HER2 high-low and gastric cancer. And you can see here HER2 status that overall 44.2% had elevation or increased expression of HER2 status, 15.7% overexpression or HER2 high, and HER2 low, which was essentially the 1 plus or 2 plus and ISH negative, that was 28.5%, and about 55% were 0. So their low population from this prospectively done pre-planned study was not as high as with their systemic literature review that they initially did, but it was still reasonably high to the point where about 45% of the population was either 1 plus, 2 plus, or 3 plus. And you can see the data there where they broke it down based on stage for HER2 low and HER2 high. You can't necessarily glean out major differences on initial staging there. So that's helpful information as well when you think about doing tissue specimen companion diagnostic testing. Can you use the original biopsy specimen? Do you have to get a fresh biopsy? It looks like it's reasonably consistent throughout. Now, I said that this was an old target or a new target. You can call it what you want there. It has been around for a long time, but quite a bit ago, we thought about targeting HER2 in bladder cancer. And this study that I highlighted here was published by Maha Hussain, who I think many of us know very well. And what she did was she did a chemotherapy, a gem, a carboplatin, paclitaxel study with or without, with trastuzumab. And what she showed there was actually really impressive objective response rates of 70%. But there was significant cardiotoxicity. 22.7% had grade 1 through 3 cardiotoxicity, and I think that really hurt the field. I think it took a step back, and I think we're learning now that targets can be really good targets, but you need to have a good drug to go with it. And in the old days, we used to abandon targets because 1 or 2 negative studies. Well, maybe the target's still a great target. We just needed better technology and better drug constructs, and I think that's what we're learning now. Now, there have been other efforts with trastuzumab, pertuzumab, not as successful with the, I'd say dirtier pan-kinase inhibitors, even with autologous cellular immunotherapies, a little bit like Xepulicel-T in prostate cancer, but something that targets HER2 instead of prostatic acid phosphatase. That was used in an adjuvant setting. That was negative. And even the earlier antibody drug conjugates against HER2, like TDM1 in breast cancer, that's been studied as well without really exciting results. And so it kind of got put on the shelf for a while. But there's a resurgence, and I'm going to go through a couple of the antibody drug conjugates that are getting a lot of attention right now. Here's trastuzumab deruxtecan, and there's the construct as you can see it. I think the key features to point out is the fact that it's a cleavable tetrapeptide-based linker system. The payload is DXD, which is a novel topoisomerase 1 inhibitor, and the DAR is 8-to-1 DAR. So this is an agent that obviously in many other cancers we've already seen good efficacy with this, and we're going to show you a little bit of data here across different tumor types and especially in bladder cancer. And so this is what led to the broad approval for HER2 3+ or greater. This is a Destiny Pan-Tumor 02 study, and you can see it was basically any solid tumor patient that was not eligible for curative therapy anymore, and second line or beyond, and then had to have HER2 expression, either 2 or 3+. They did take local testing as well, and they allowed prior HER2 targeting therapy, actually. Of course, ECOG had to be 0 or 1, and you can see the tumor types listed above there, but we're going to focus a little bit in on bladder cancer. So you can see the endometrial and cervical ovarian data in the GYN world. They are super excited about this. In bladder, I think it's interesting as well and very promising. For the 3+ population, 56.3% objective response rates. And for the 2+ populations, 35%, overall being 39% objective response rates. So here's a little bit more data here, as you can see, with waterfall plots there from bladder cancer, and then you can see the swimmer's plots so you can get a look at durability. But I think across the board for all these different tumor types, you can see there's clearly nice waterfall plots and efficacy. So I think based on this data, I think the FDA was very excited about giving the approval. Here's just the PFS and OS, and you can see you can't really determine any key differences, so I'm not going to spend a lot of time on this, whether the patient was IHC 2+, whether the patient was IHC 3+, and then overall, PFS, OS, the survival curves all look very similar there. Now, I did mention HER2 mutations earlier, and we haven't really known what to do with these activating mutations. But here's a little bit of data in bladder cancer using trastuzumab deruxtecan from the Destiny Pan-Tumor 01 study. It's a small number of patients, but there were 7 patients with urothelial carcinoma and HER2 mutations that were pre-specified, and they received standard dosing of trastuzumab deruxtecan. And you can see a couple patients responded there. But we're seeing this already in other cancer types, especially in breast cancer. We're seeing good response rates in breast cancer and in GYN malignancies for the HER2 mutation patients. And so even though it's not common, usually in the single digits in terms of percentages, I think it's an unmet need, and I think it's good to start to see some of this data. Now, what about combination approaches? I'll continue with trastuzumab deruxtecan. This was a study that we were really quite involved in here, and this was taking trastuzumab deruxtecan with a couple different dosing levels in combination with nivolumab. And it was actually a breast cancer and a urothelial cancer study, and was broken down to a couple breast and a couple urothelial cohorts based on HER2 high and HER2 low. And the HER2 low in urothelial didn't accrue very well, but we did fully accrue the HER2 high expressing populations. And here you can see the waterfall plot with TDXD plus nivolumab there. The objective response rates ultimately were 36.7%, which is kind of what we saw in the Pan-Tumor Destiny study for the 2+ population. So we were hoping for more synergism with IO. We couldn't quite see it, but still reasonable objective response rates here. And again, I mentioned the FDA took that Pan-Tumor Destiny data and said, we're going to give you an accelerated FDA approval. The approval is for those with unresectable or metastatic HER2 positive, that's 3+ solid tumors who've received prior systemic therapy and no satisfactory alternative treatment options. But that being said and done, the NCCN guidelines have just been updated, and they said second or any later line therapy as long as the patient's IHC 3 or 2+. So I think it's helpful there because it's a little bit looser than the accelerated FDA approval. Now, safety findings, we have to talk a little about safety here. 41.5% had grade 3 or greater events. SAEs were at around 10% here, but only around 10% leading to treatment discontinuation, although a little bit over a third had a dose modification, and small number of patients there, 1 patient had associated with death. But neutropenia and anemia, the most common adverse events. Of course, we always think about ILD, pneumonitis. That's something that we always have to keep a close watch on with this agent. So this leads to the kind of 5S rules, which is you got to screen often. Every time you see the patients in the clinic, get O2 sats, listen to their lungs. You got to scan a little bit more frequently, certainly every 6 to 12 weeks to scan to look for signs of pneumonitis. And then you got to work with an entire team. As we talked about, it's multidisciplinary. So we work closely once we find findings with our pulmonologists as well on this. And we have a low threshold to hold treatment. Okay. Really, really low threshold because you certainly don't want this to explode. And then the mainstay of treatment is really giving steroids. And so you can dose adapt to toxicity grades, usually starting around 1 mg per kg. Now I want to move on to the next agent. This is disitamab vedotin. This is another HER2 antibody drug conjugate. This is using the similar linker that enfortumab vedotin uses and also the same payload with monomethyl auristatin E. The antibody is not trastuzumab. It binds to a different epitope. It's hertuzumab there. But here's the monotherapy data. You can see in the 2 to 3 plus, they're at HER2 high. Nice waterfall plots there that you can see with very high objective response rate, 62.2% for the 3 plus and 39.6% for the 2 plus patients. And even in the HER2 1 plus patients, you still see objective response rates in the 26.3% range there. And there's been combination studies. So this was done in China. So it's disitamab vedotin with their IO of choice, which was toripalimab there. Really impressive waterfall plots there, really impressive spider plots there, and you can see a confirmed objective response rate of 71.8%. So what about combination approaches and additional approaches with disitamab vedotin? Currently the phase 2 trial is open, and it's either first line or second or third line can all be eligible. For the first line patients, it's patients that are HER2 either low or high patients, and they get randomized to DV pembro versus disitamab vedotin monotherapy. And for the later line patients, there's a HER2 high and a HER2 low cohort DV monotherapy. And then here's the randomized phase 3 that's ongoing. This is first line for patients that are HER2 expressing 1 plus or greater, and they're randomized to disitamab vedotin plus pembrolizumab versus gemcitabine with your platinum of choice, cisplatin or carboplatin, dual primary endpoints of PFS and OS. Of course, we always have to talk a little bit about safety here, and with disitamab, it's as expected. Monomethyl auristatin E is an antimicrotubule inhibitor. You do have to worry about peripheral neuropathy there as well. It does have an antibody that internalizes very well, so there might be a little less peripheral neuropathy than one might expect with other ADCs that have MMAE, but fatigue is kind of one of the more common things we see there, and you can see all the other things listed here. I'm not going to go through that entire busy table. I'm just going to wrap up with some take-home points. HER2 expression is not uncommon for urothelial bladder cancer. I think it's at least 1 plus or so, probably for about half the patients, and in the HER2 high expressing range for maybe about 15% of patients. Antibody drug conjugates are tried and true technology now. The construct does matter. The antibody internalization matters. The linker matters, how stable that linker is there. The payload matters, and the drug-antibody ratio, or DAR, matters to limit off-target effects. But there's a lot of different ADCs that are coming down the pike, certainly including HER2 as well. This includes trastuzumab deruxtecan and disitamab vedotin, and we already have an FDA accelerated approval for trastuzumab deruxtecan, as I earlier mentioned there. So I'm going to turn it back over to Petros to run us through a case.
Thanks, Evan. Great job and a wonderful data overview. And you have done so much work in all the above domains, including enfortumab and the HER2 ADCs. So this is a 68-year-old patient presenting with, again, progression after prior treatment, fatigue, back pain. This patient had, again, carbogem, 4 cycles of chemotherapy, then switched maintenance avelumab as per the Javelin Bladder 100 trial. CT showed bone mets, progression. This patient started enfortumab vedotin. As Evan mentioned, this is probably the most commonly used ADC after chemo and IO based on the EV301 trial that Jan showed. This patient had EV, did very well for about 9 months, but then had progression. The tumor next generation sequencing showed HER2 amplification, interesting, and the immunohistochemistry, where the label is on, showed a HER2 plus 3, which is about 15 to 20% of patients, as Evan quoted. So I will ask you, Tian, here, do you have this patient, had chemo, maintenance avelumab, EV, no FGFR alteration. What do you do here? You have a HER2 plus 3. I suppose you have SATSI or TTXD. How do you decide about that?
It's great that we have access now to a tumor agnostic approval, and so I think it's important. We've been used to doing NGS testing for our patients with bladder cancer, so the HER2 certainly comes up as one of the results that come back. So that's important. The IHC, though, I don't know that all of our pathology labs are reflexively testing. So having that as an additive, is great that this particular patient already had that done. So with an IHC 3+ and with the data that Evan just showed us, I think it's important to offer a HER2 targeted ADC, especially if she's had good tolerance to prior ADCs, the EV, and her performance status continues to be good, offering her next line therapy. So in this case, I think TDXD would be really good to try.
Thank you, Tian. Evan, how would you decide between TDXD and SATSI in that case?
Yeah, I mean, I think in this situation, since we don't have survival data for either TDXD or SASE, I mean, we saw survival data, but not positive survival data, I would look at objective response rates. And so for sacituzumab, it's around in the 30% range. For TDXD, because this patient's 3+, we expect it to be over 50%. Objective response rates at 50 to 60% range. So I think at that point it's a math game, so I would pick TDXD.
Interesting, great discussion. It's great to have options for our patients. So I think we covered most of them. So let's say, Tian, if you choose TDXD or SATS either or, tell us a little bit, let's say TDXD in that case, what will be the discussion with the patient, dosing, follow-up?
Yeah, I mean, I would follow the label and continue that treatment and follow them very closely. I'd be curious, actually, we have not participated on the combination trial. I'd be curious if in this particular patient, the waterfall plot for TDXD with pembrolizumab or with nivolumab was so nice that, I'd be tempted to think about re-challenge with the combination too, if we were able to get it. So certainly not an approved combination yet, but that waterfall plot certainly was pretty impressive.
Interesting. Thanks, Tian. So we have a few minutes left, about 10 minutes or so, and we're going to make it fun. I'm going to ask you many questions. I will try to get as short answers as possible to make sure we cover the audience here. So the first question is, can you dose adjust SATSI if needed and maintain efficacy? I can probably take this one. The answer is yes. Those adjustments can happen with SATSI. Usually you go from 10 mg per kg down to 7.5 mg per kg. You can potentially go even lower to 5 mg per kg, so you allowed up to 2 dose reductions. You can do dose holds as you need. I think with the use of growth factor up front as primary prophylaxis, actually, anecdotally, in my practice, I have seen less need for dose reduction because of the growth factor use, but can still you have other reasons like fatigue, diarrhea, other reasons to do dose reduction. So it can happen, and you can follow the package insert. When do you send next generation sequencing and IHC testing? I suppose, Tian, at the time of diagnosis of metastatic disease, would you do both?
Yeah, often even earlier. So as in our particular practice, our urologists are very proactive in sending off NGS testing. So as the cystectomies are being done, if there's residual tumor, those specimens are being sent out. If people are presenting with metastatic disease and they haven't had NGS testing before, we're proactively sending that out, particularly for FGFR alterations, but now also potentially for the HER2. And certainly we've been seeing HER2 return on our NGS testing reports, and now it's become more actionable.
Absolutely. It's great to have options. One question is about how do you describe to a patient the need for growth factor? I think the simple way to say it, we need best supportive care to optimize dose delivery, and this GCSF can help your bone marrow generate white blood cells to fight infection. So we try to explain to the patient the rationale behind the growth factor in that case. Evan, I have a good one for you. What level of expression of the target, the antigen, is needed to see a response in ADCs?
Yeah, I mean, it's a really good question. I think it depends, and that's the problem is that if you think about what level you need is, it's not just what level you need for your drug to actually find the target, but there's other factors like how well is it internalized? Where is the antigen expressed? Is it membranous? Is it intracellular? Maybe it's hard because the ADC is floating around. And then there's other ADCs that are more cleavable that can be cleaved at a higher pH where the payload's floating around. So I'm skirting around the issue because I don't have a great answer. Another problem is that, for instance, with enfortumab vedotin, their immunohistochemistry that they did in their early studies to get really high H scores, they used the exact same antibody for immunohistochemistry as on the construct for enfortumab vedotin. So really, really high H scores. But that being said and done, it's a proprietary antibody that we can't get a hold of. And so all the commercial Nectin-4 antibodies that are out there are very, very poor, and you get very low staining rates. So I think the reason I'm saying all this is that it depends in every situation based on the antibody, what epitope it binds to, how sensitive, how it is. I think it's going to be individualized case by case, and whether IHC is going to be adequate or a good biomarker or not, ultimately, it'll depend situation to situation. So we still have a lot more to learn.
Totally agree. It's so much to learn about the mechanism, the kinetics, and the quote-unquote trafficking of the payload in the tumor microenvironment for bystander effect. So Tian, quick question. How about accessibility of ADCs to the community practice? Do you see any challenge there, or it's pretty straightforward?
Yeah, no, I think as these agents are being approved and as we're learning more about them tonight, for example, hopefully the awareness for our community oncology partners is increasing. And as they're understanding and gaining experience, hopefully they're able to offer it to more patients. I actually think there's a lower threshold, right, for agents like sacituzumab govitecan, trastuzumab deruxtecan. These are agents that are given in the breast cancer populations, and so some of our community oncology partners might have experience in those populations, and maybe even more so than GU-focused oncologists like ourselves. So depending on their comfort level, but I would say, given the totality of the data, that these agents deserve a try, and as they become aware of these approvals, hopefully they're also using them in their practices.
Great points. Thank you, Tian. Evan, EV Pembro apparently is, showing impressive data. It's probably standard of care in the frontline setting in the US. What do you do second line after progression to Pembro EV?
Yeah. For lack of having anything better right now, I think we're doing gemcitabine, carboplatin, gemcitabine, cisplatin. That's not because we have data in that second line setting after EV Pembro. It's just that it's been the tried and true first line agent, and oftentimes when you don't have a clear second line agent, it moves into that situation. So I would say it's an unmet need, and there should be and likely will be many clinical trials with novel ADCs, let's say, that go up against chemotherapy in the second line moving forward. So look forward to seeing those.
Absolutely. So Tian, you have a patient, Pembro EV, does great for a while, has progression, FGFR3 mutation, neuropathy grade 2. What do you do? Carbogem, or you do erdafitinib?
It's a great question. We don't know what resistance looks like. We don't have enough follow-up. We don't have enough progressors. So EV Pembro progression certainly is sort of an area of unmet need right now that we need to characterize better. I would say that somebody who has an FGFR known alteration is somebody that I would certainly be thinking about erdafitinib, other FGFR inhibitors as they come along. We have some in trials now, so those would be good options. Chemotherapy in the EV Pembro refractory setting, I think we're just extrapolating that understanding of chemo's objective responses, maybe somewhere in the 30-40% range. But if they have a known alteration, and certainly oral treatments is easier on the most part to tolerate than IV chemo, and our choice is there. But we can discuss both with the patient and have them decide with us.
Great points. A couple of more questions before we go. HER2 testing, there's a question about that. I think it's in a lot of discussion with pathology departments. I know at Ferhatz and UW we discuss with pathology colleagues. to standardize the testing with the right antibody, the right assay, the right scoring system based on the gastric cancer scoring algorithm. So it's important take-home message to have this dialogue with pathologists to make sure the HER2 testing is done properly. And the label right now, as Evan mentioned, is only for +3 IHC. Evan.
Many of your commercial NGS assays now are adding IHC as well. I believe, is it Tempus? Maybe Caris did as well, and I just heard that Foundation did as well. Okay. So I don't quote me on all that, but I know at least one of those companies I saw added it. I think it's either Tempus or Caris for sure, and I heard Foundation did. So I'm going to be surprised if they don't do it in the future, because it makes sense just to get everything you need tested in one shot.
I agree with you, and I think from the business standpoint makes sense. Evan, is there any clinical evidence that different cancer types may have different toxicity with the deruxtecan compound for pneumonitis?
Yeah.
It's a hard one.
I don't know the answer to that one. Certainly the target and the payload matter. So, and expression of the certain targets in the lungs are going to matter as well. But, in regards to the tumor types, obviously lung cancer. Right, lung cancer patients always have higher rates of pneumonitis and ILD. So that I can say yes. For others beyond that, I think it's a little hand wavy extrapolating.
That's a good question. And maybe prior radiation, who knows?
Yeah.
There was a question about diet. I don't think we have a lot of data, but I always send patients to nutritionists, which is always a good idea. And the last question, Tian, would you ever re-challenge someone if they have Pembro or EV before separately, and then you exhaust the options? Would you go to a Pembro EV combo?
This is an interesting one. So I actually had a patient who had both EV and Pembro in sequence monotherapies. He had moved into Dallas, set up his care with me, and I said, well, maybe let's give the combination try. He actually has had stable disease now about over a year. Wow. So, I would say, if their pembrolizumab was far enough before, right, there's 6 to 9 months time for those T cells to be exhausted and re-challenged to make sense, then perhaps in those patient populations, we can consider the combination.
Thank you, Tian. Evan?
Yeah, I mean, it's similar to what Tian said there. I think that there's no definitive data there. I would be more enthusiastic to do combination, let's put it this way, with EV added in than Pembro added in. Oh. And the rationale that I have for that, or actually, am I saying that wrong? My rationale is this, is when you give somebody an IO therapy like Pembro, Nivo, something like that, the receptor occupancy actually lasts quite long, 6 months out, et cetera, et cetera. So the whole re-challenge concept only makes sense to me if the patient's gone a long time off the IO and then relapse, because there's all these discussions of, the patient's progressing on IO, we're going to add their drug X and then just switch the IO to a different IO, like from Pembro to Nivo or Nivo to Pembro, or even just continue the Pembro. And to me, that doesn't make sense to me. There's a lot of concepts floating around out there, and doesn't make sense to me because the receptors are occupied. So just continuing that, I'm not a fan.
Got you, based on how long it stays in the receptor. Wonderful discussion. Any last burning question from the audience before we thank you? Sounds like we're good. We're going to be here for a few minutes if you want to find us, ask questions. Thank you so much for spending the evening with us. Evan, Tian, and me are super happy to be here, and thanks to you who are here, and thanks to the audience. Thanks to PeerView, and hopefully we'll see you again for more educational events in the future. Enjoy the rest of ASCO.
Have a good night.